session. This is appropriately doomy and gloomy sounding, the name of it, which is dealing with disasters and complications. So we're going to start off this afternoon's sessions. Dr. Boss is going to come back up to the podium, and he's going to talk to us about atherectomy for heavily calcified vessels, how to choose which lesion and which device is best for which lesion. This is a carryover from the last session. So Samir, if you would, lead us off this afternoon.
All right. Thank you all for having me here. So I'll be talking for the next 10 minutes about heavily calcified vessels and what atherectomy device I choose. So this is my disclosure. I don't think it's related to what I'll be talking today about. The objective of this talk, we're going to talk a little bit about calcium, go over the device, and if there is any data behind it. I'm going to present a few cases from my lab, and then we will conclude. So who are the patients that we should be watching for heavily calcified vessel? These are the older people with this diabetes and chronic kidney disease. Simple definition of calcification, I'll say if you have on a plain X-ray, if you see calcium on both sides of the vessels, more than 1 centimeter in length, we can say this is a severe calcified vessel. If it is less than 1 centimeter in length and on one side of the vessel, this is at least moderate, but definitely not severe. That's a way of looking at it. But as we all know, angiogram is underestimate the calcium. You can take a look at these pictures. You see that it appears to be on angiogram a soft lesion, and you might choose like just a plain balloon angioplasty for treatment. However, if you do a CAT scan, you see that severely calcified vessel, and probably if you choose to treat it with a balloon, you'll end up with dissection or bailout stenting. At the same time, you can tell here there's two types of calcium, and I just want to clarify that look at this train track for just plain X-ray, and you think this vessel is severely calcified. If you IVUS that vessel, you see that the lumen is actually a good size lumen, and there is not too much calcifications inside the vessel or in the intima. This calcium is in the media, and that's why I put the slide here so you guys can say probably you need like a tool, IVUS, or some OCT to determine how much calcium in this vessel prior to treatment. So as we said, there is the two types of the calcium that you'll be aware of, the intimal calcium, which is going to cause a problem, and luminal obstruction. And you have also the media calcium, which is usually, it doesn't interfere with our approach as much. So why we have to think about calcium, I'll say number one is, of course, technically challenging intervention, whether difficult to cross or deploy a balloon or expand a stent. It is associated with a high procedural complications, whether dissection or perforation. And of course, there is a higher risk of a clinically significant emboli with treating calcified vessel. And this has been proven that 74% in data showed that calcified vessels is the reason of dissection. The same concept, you know, challenging of a lower success of procedures associated with a treat calcified vessel. So we heard about the new devices that's out there. I'm going to be mentioning what's available right now. There is a few of them in the market, and most of them they tried. The laser atherectomy, it's a great device, works the best in thrombotic lesions. As we saw previously, that in-stent restenosis is a perfect device for treatment. However, in the calcium, it's limited. The Jetstream, it's a front cutter with a active aspiration. It's 7 French, used to be 8 French, now 7 French. Is good device for, I think, above the knee, used in the calcium. There is a study which is a single arm multi-center treat calcified vessel with Jetstream, showed that it's effective, it works. And about 2-3 weeks ago, Bill Gray published also a paper about the success rate and long-term patency with a Jetstream treating severely calcified vessels. The rational atherectomy, and this is my device to go above the knee. I will say this started with the definitive calcium trial. 80 or more percent of these patients were severely calcified vessels treated successfully with a great results with the directional atherectomy. So if I look at the lesion and when I choose my device, especially with using a directional atherectomy, I'll say I'll go with the TurboHawk for calcified lesion. If I want to obtain a larger luminal gain, depend on the vessel, I think this device will get you the best lumen and the bigger lumen. Of course, I have the ability to place a filter in this device and what we call it the no stent zone, whether the common femoral or the popliteal artery. The cons of this device is a bulky little bit. Sometimes you cannot cross it. You need maybe to pre-dilate prior to treatment. This is a common femoral artery, severely calcified vessel. Images were taken by IVES. We were able to cross with the 035 wire, place a filter in the SFA, and did a TurboHawk with a minimal pressure balloon inflation, decent results. I put this picture just to show you that this vessel is severely calcified, and the amount of the calcium, sometimes you underestimate it. You can see here that if you don't put a filter, this all calcium that is going to be a significant, clinically significant distal embolization. CTO with a calcified vessel, it might be a little challenging. You see here, like we were unable to advance our device, so we have to, after we cross with the wire and the catheters, we balloon with a 3 millimeters balloon, and eventually we're able to do a TurboHawk LXC with good, decent results. Those are the areas that I said, the no stent zone area. I know that a lot of us here from previous, you can put a stent like whether a Sopera or a Viabond, but I tend not to stent in the popliteal artery, and this is a severely calcified vessel. We were able to cross it, and with a TurboHawk achieved good results after small balloon inflation. The patient has in this aortofem bypass. We are unable to come up and over, severely calcified common femoral. We went from the brachial artery, able to put a filter distally, and with again TurboHawk and balloon angioplasty, decent results. This just to show you that there is a large amount of calcium, and I think if this patient has a single vessel runoff, this is significant distal embolization. You should be aware of it. The other device that I use frequently and regularly is orbital atherectomy. I think it's a perfect device below the knee. It has a great ability to drill. You can cross with it. You can choose to treat multiple vessels in it. The cons, I think the device, although I argue with sometimes that you change the vessel compliance, and although you don't create after the few passes a lumen as big as other devices, but I think with the change of the vessel compliance, you can, with a small inflation of balloon, create the same size of the lumen. And, you know, there is some suggestion of there is distal embolization with the device. However, I've done so many of those, and I don't think it's that significant. This is a very small particles that I don't think it cause any problem. So the device came on the market with the OASIS trial, and that after that was confirmed with 1 and 2 and 3 confirmed trials. It studied in the calcium, studied below the knee, the calcium 360. It's a 100% calcified lesion, and results were outstanding. Of course, it's not a randomized trial. It was against balloon angioplasty, but again, it's proven the efficacy, especially below the knee. This is the patients who would have a severe totally occluded distal anterior tibialis going into the pedal artery. And as you see, none of the other atherectomy device can go in that far. And at the same time, taking a risk of balloon angioplasty alone in a calcified vessel might cause a dissection in an area you don't want it. So we were able to cross it, and then with 125 micro, achieve good results with a 2025 millimeters balloon post-inflation after that. This is an SFA, and again, as I said, my device is above the knee. Most of the time, I use a SilverHawk or directional atherectomy. Below the knee, I tend to use more of CSI. However, sometimes, as I said, you can't cross. So we were unable, this is almost a CTO, unable to cross with a 035 catheters. We switch it into a 014 wire. We're able to put a 20 1 to 5 micro to create a channel and upgrade our device, and a 6 millimeter balloon was fully expanded. I tend to treat SFA without stenting. I left it and I'll watch the patient clinically. Another case of a totally almost occluded common femoral with a severely calcified vessels, we were able again to create a little channel with a small device like a 125 micro upgraded to 2.0, multiple run and 7.0 balloon placed and wide open common femoral. You can take a look at this common femoral. You see like there is some haziness, but I think you look at the balloon, it's fully expanded. So the lumen really, it's like achieved about 7 millimeters lumen. The angiogram looks, there is some calcium maybe in the wall, and that's what you see on the angiogram. So how do I choose my device? I look at the lesion first. I look at whether thrombotic versus non-thrombotic. If there is a thrombus, I will say, and calcium, I will say the Jetstream is a very good device. Jetstream has the active aspiration. You can aspirate any thrombus in addition to good crossability for calcium. However, if the lesion is not a thrombotic and it's I need to achieve a larger lumen in a above the knee vessel, I will say maybe a directional atherectomy will be a good device to use, especially if there is a single vessel runoff, if there is a risk of distal embolization, I need to do the filter. Those are the things that I think about. Where is the location of the lesion? Whatever is a place that I definitely want to avoid stenting versus not. This is where I make my decision, what kind of device I use. And finally, what's my goal? Am I treating a claudican patient that I need a large lumen and long-term patency, or I'm treating a critical limb ischemia that I'd like this vessel to be open for the next maybe 6 to 8 weeks to clear. So those are the things that I think about. And then finally, I really think you should be familiar with the device that you use and know how to use it very well, because that's the best thing for you to avoid any complication. Thank you.
Thanks very much, Dr. Abbas. Our next speaker is going to be Dr. Jeff Wang from the greater Washington, D.C. area, who has a very provocative talk dealing with disasters, extensive thrombotic occlusions. Please enlighten us, Jeff.
I wouldn't necessarily call it provocative. I call it more really painful. But first, I'd like to thank the committee for allowing me to talk on this topic. Here are my disclosures. So I'm going to leave you with one concept up front. We'll go through the cases, and then we'll go through some of the other finer points. But in thrombotic complication cases, or anytime you're dealing with an extensive amount of thrombus, you need to break the case down into two parts. One is your thrombus management, and then your secondary intervention, okay? If you break it down in this way, it actually makes it a lot easier to get through it than opposed to trying to kind of mishmash it all together, in which case it can lead you into a downward spiral pattern if you don't clear one before the other. So here's a 64-year-old female. She had a left shin and a foot ulcer. She's a previous smoker, type 2 diabetic on insulin, comes in for angiography intervention. She has included SFA proximal with reconstitution of the proximal popliteal. 5,000 units of heparin was given. ACT is 154. Additional 5,000 units was given, and ACT now jumped up to 204. So I crossed the SFA and angioplasty the proximal portion. So you can see here, it's got a little stump. Distally reconstitutes in Hunter's Canal in the popliteal. It's pretty straightforward. Cross it, angioplasty. And this is what your runoff looks like. It looks all right, except for there's some clot in the bottom. So at this point, you got a couple of options. One, you can use one of the thrombectomy devices. You can use lytics. You could stent it, although that's right across the knee joint, and I wouldn't advise that. You can prepare for open surgery. I wasn't quite there for open surgery yet, and I am a vascular surgeon, so I said, let's do some percutaneous thrombectomy. I redosed the heparin. Okay, the ACT is now 280. Angiojet thrombectomy was attempted, wasn't successful. I power pulsed in TPA 8 milligrams and then waited 15, 20 minutes, went back, tried to suck it out, still wasn't successful. But now the patient's complaining of severe leg pain and foot pain. So reshoot the angiogram. You can see I'd intervally placed a stent as well, but it's completely out. Nothing. So I was like, that's a problem. So what now? I thought about it, and I'm like, Well, did I dislodge some atheroma, like the previous speaker had mentioned? You know, you can dislodge calcium, which does not lyse out. So I was like, maybe I should kind of burn it out with a laser. You know, should I take the patient to the OR, lytic catheter, jet stream, suck it out? I thought about this, and I was like, well, this is getting back to the dealing with one part at a time. I was like, the laser can burn through some thrombotic lesions, especially if you're along CTO or ISR, but that really is not, it's not really useful in the situation where you have a huge thrombus burden. Jet stream, same kind of thing. I'd already tried angiojet, so I said, you know what, let's leave a lytic catheter and see what happens. So placed an echo, started lysis, rechecked some labs when the patient got to the ICU, and I noticed the platelets were 82, and pre-procedurally the platelets were 230. So I thought, well, maybe this patient had HIT. I did send a hip panel at that time, but going through this case, I didn't get the hip panel back for 2 days, so I just assumed they had HIT. I switched the heparin sheath infusion to igatroban, and I lysed the patient overnight. So when I went back for the intervention, I stopped the igatroban and started angiomax for the procedural portion because it's much more controllable. So after lysis, now we got some flow going back into the calf. There's still a little bit of a thrombus there. So do you continue lysis? I didn't think so for such a small amount. Percutaneous thrombectomy, well, we tried it before. Didn't quite work, but I actually tried it again in this situation. Open surgery or leave it alone, stent across it, whatever you want. I thought if I was going to stent across it, I'd want to use a covered stent in this situation to not cheese grater more thrombotic material down the leg. I did an additional angiojet thrombectomy, which then worked out fine after subsequent angioplasty. And so then I went back and then fixed the anterior tibial and then had good runoff in the calf. So I ended up DCing the patient on a Rixtro for 30 days. Patient's ulcerative healed and she's doing well. She's actually about a year and a half out from this. So what did I take away from this, which is thrombosis with an appropriate ACT, you should consider switching anticoagulant agents. And normally, don't fool yourself. Your thrombotic occlusions intraprocedurally are not typically due to HIT. They're due to some technical issue that you had during the case. One thing that I'd noticed was porcine insulin exposure on top of previous heparin exposure. Both of those can actually cause an increased risk of HIT. So here's another case, 74-year-old male, status post-cardiopulmonary arrest. He's on a ventilator. He had he's elevated troponins, known coronary disease, and previous MI. He's already dialysis dependent, and he's on pressors right now. Initially, I was called for a clotted AV graft, but also he noted that he had a left cold leg. So this is what his initial angiogram looked like. So clearly there's some stenosis in the external iliac, some tortuosity. That's actually pretty easy to deal with. I had difficulty getting up and over this one, so I stuck the other groin and then just did it from the left groin in a retrograde fashion. But then as I was trying to get a sheath back over, and that included body flossing and trying to push the sheath through, for whatever reason I couldn't get it through. Here's an angiogram, initial angiogram of the leg. It shows an occluded long segment SFA occlusion. My assumption was that he had chronic disease, which then acutely occluded with low blood pressure, on pressors, all that kind of stuff. So he didn't really have so much of a reconstitution, maybe an island reconstitution of a blind segment pop, and just collaterals, and not even robust collaterals in his calf. So I actually thought about, well, we could just leave it be and amputate it later, because he did recently have an MI. This admission was pretty sick, but I said, well, you know, the leg is already pretty much shot if I don't do anything. So I said, okay, let's go ahead. I'll do tibial access, go up retrograde, and so I ended up running the angiojet from downstream up through the SFA and popliteal and tibial segments. So now we got a little something going. We can work with this. Ended up, performing angioplasty and stenting of the segment. So then had reasonable flow down his leg. And this is actually just a different, even though it's not on topic, it's a little different teaching point in terms of tibial access. You just have to watch out that when you put anything that's relatively large, and I say relative is anything larger than a micropuncture sheath, you have to worry about damaging the vessel itself, which in this case, I had a 6-French sheath in his AT, so clearly it had damaged his AT. So I ended up removing the sheath, putting a radial compression band over my access site, and then came back down with a balloon, angioplasty the anterior tibial, and then ultimately restored flow through it. So this guy's leg actually was saved, except he lost 2 toes, which I felt was acceptable in that situation. So I'd like to just leave you in conclusion that you got to remember that you got to really break the case down into 2 segments: thrombus management and then secondary intervention. When you're clearing the thrombus, you got to accomplish clearing the thrombus before you start going to ballooning large chunks of thrombus, because that's just going to send it further downstream, and you're going to end up with a worse problem, because you can recover most things if you've got thrombus in the SFA, popliteal, and even in the tibials. Once it starts going into the foot, into the distal smaller circulation, that's when you start, you're going to lose the situation and lose the leg. Make sure that you have appropriate thrombectomy devices and know how to use them. And most importantly, when you see a lot of thrombus, you can tend to get nervous. Just make sure you stay calm, work through the case methodically, and now is not the time to take shortcuts. When you're like, I'm almost there, oh, well, I'll just do this, angioplasty will be fine. Probably won't be fine. So just make sure that you get through it, and also know your limitations, know when you need to call for surgical help, and also know your patient's limitations too. The reason why I showed the second case was that may have not been the smartest thing. I could have been up here saying, oh, and then the patient expired because I was doing this long procedure while on pressors. So just make sure that you know both. Thank you very much.
Thanks, Jeff. That was a terrific talk. Some very tough cases with a really spectacular outcome. Our next speaker is Dr. Andre Pop. Andre is going to talk to us about preventing and treating embolization and endotrash during complex endovascular intervention. Welcome, Andre.
Hi. Had some issues with my slides, so they were kind of put together again at last minute, but I hope it'll work. So, we talked about atherectomy and all sorts of nasty vessels. We talked about thrombosis.
Yes.
I'm going to talk about how to prevent problems with distal embolic protection, and how to anticipate problems and prevent them if possible. So, I don't think I have any relevant disclosures. So, I agree with the previous speaker. I think planning is crucial. You must decide what type of trouble and especially what type of junk you're going to expect to see go flying. Samar and I trained together, but I'll disagree with him a bit. On the Diamondback, my experience has been that you get these little pebbles of calcium that you fish out of the embolic protection device sometimes, and those will not respond to any TPA. The access sites are very important, because if you have certain accesses you can't protect yourself. The embolic protection options are there, but are somewhat limited, and you always have to think about what your bailout options are going to be down the road. So the kind of trouble that we can run into, obviously, dissection, perforation, embolic material, the thrombus, whether it was there when you started, whether it's catheter-derived, what we saw in the prior case, calcium, and soft embolic material. Our practice is very, very heavily CT-oriented. I would say 90+% of our cases that are elective have had a CTA before. And when I see calcium, I'm much less worried than when I see low-density stuff on CT, especially if it's abundant. So we use CT. Especially when you have long segments of total occlusion, you have to think of multiple access sites. We use pedal access routinely. When you do pedal access, however, if that's your only access site, it's going to be essentially impossible to protect yourself. That's why generally we body floss, and we abandon our pedal access site, and we put a filter in from the either antegrade or retrograde access site. It's important to know the distance to bifurcations when you use distal embolic protection devices, because the distal embolic protection devices have a certain length that you have to allow in order for your atherectomy device or for your stent to be successfully deployed. There are ways to cheat, and we're going to talk about those, and not everything, unfortunately, can be protected, and sometimes you're in the situation where you have to choose the more important branch and decide to protect that one. So, I personally believe in pressure monitoring, and whenever I have a sheath in a patient or a catheter, I sample pressures from that. I know not everybody does that, but sometimes things that don't appear significant in angiogram will be very significant when you have a catheter across, and when you have stagnant flow and you have a dampened pressure, that will result in clotting even though your anticoagulation regimen may be adequate. So lytics, if you have clot, are a great bailout strategy, but if you've atherectomized and embolized either soft tissue or calcium, it's not going to thrombolize. And you have very organized clot, that's also tenacious, and it can take sometimes more than 24 hours to get it dissolved. So the best solution is to not have to deal with these issues if you can avoid it. So embolic protection devices, not everybody is using them. They're not cheap. There's no reimbursement for them. They're not mandatory. But in my book, they're not to be skipped with atherectomy or with lysis unless you don't have an option. So with all embolic protection devices, this is one of the things where I see people getting in trouble all the time. If you lose flow and you have an embolic protection device, the first thing you have to do is aspirate before you retrieve the filter. This is a lesson that we learned initially in the carotids. You can get so much debris behind the filter that the artery gets occluded. And if you capture the filter at that point, you'll capture a little bit of that debris and the rest will go flying down. So whenever I'm in this situation and I have a filter down, I go with a export catheter or some sort of aspiration catheter. I suck out as much debris from above the filter before retrieving the filter. The other problem that I see all the time is filters have a tendency to move, and it's very hard sometimes to keep the filter on the screen when you're doing an intervention further up. There are tricks to that. You can mark the end of the filter. The spider has a transition zone of 2 different colors. You can mark that. But you have to make sure your filter doesn't move, because if the filter moves up and you're in a bigger diameter vessel, you can embolize around it. If your filter moves down, you can embolize in branches. The other problem that I see all the time with embolic protection devices is when you're trying to retrieve them through self-expanding stents and the filter is full. Both of them, both Spider and EmboShield, sometimes can grab the walls of the stent graft and get caught in the struts, and that's not a good situation to be in. So sometimes it's best to avoid deploying them in self-expanding stents, especially just beyond self-expanding stents, if the stent is not well opposed. So you have to know what's compatible with what. With Silverhawk or Turbohawk, you use Spider. With Diamondback, although it's off-label, we use EmboShield. With Pathway, you can use either. With Phoenix, it's recommended you use EmboShield. And my favorite device for below the knee is the rotablator. You can't use an embolic protection device, but most of the time you don't need to, because the particles are truly small enough that they don't cause a problem. Spider has a relatively long tip. You can cheat by burying the tip of the Spider in a branch and leaving the basket above in the trifurcation. You can deploy it through an 035 catheter. The advantage of retrieving it through an 035 catheter is that you maintain your wire position. The disadvantage is that if it's really full, you may not be able to retrieve it. The marker on the wire allows position maintenance, and you may lose wire position during retrieval if the filter is full again. The EmboShield, it's coaxial, not eccentric like a Spider. It's less vulnerable to vibration, and that's why Diamondback likes it. The supplied wire in the EmboShield is too short to use for peripheral procedure, so you have to replace it with an 0017 Viper wire. On the box, the EmboShield says it has an 018 tip, but 017 is good enough so that the EmboShield doesn't embolize. And once you retrieve, you lose your air position. Protection is crucial. I have those, as I said, nope, my slides didn't make it. I apologize, but my pictures that I loaded didn't make it. That's it. Sorry.
Okay. Thank you, Andre. All right. Our live case, Miguel's not quite ready for, so we're going to continue to push through with our talks. So I would invite my good friend, Dr. Eric Dipple, to come back up to the podium. Eric will discuss the identification management of post-procedure hyperperfusion syndrome. Some tips and tricks, I'm sure, are in store for us. Eric?
Thanks a lot, Peter. This is something that's typically thought about after carotid stenting and hyperperfusion in the brain. Obviously, that's a life-threatening problem, but this is more related to hyperperfusion in the leg after intervention. I intentionally made this talk relatively short and simple because I knew it would be late in the afternoon and most of you want to leave or are sleeping. So we're just going to kind of be brief with this and just talk about some basic stuff about what this problem is. It's kind of a practical thing. You know, when I came out of my fellowship and the first time I saw this, I really didn't know what the hell it was, and I kind of had to figure it out on my own. So it's actually a fairly common problem. So this is a 93-year-old lady who, bless her heart, still lives by herself, and hopefully that would play. Is that going to play at all? Can we get that to play? No. Well, it played in the speaker ready room. No, go back one. Anyway, so this is a 93-year-old lady. I don't know if they can get that to play in the back at all, but that was playing before. She lives by herself. She's had several months of kind of resting foot pain. She never really sought attention for it. Claudication after walking approximately a quarter of a block. And her ABI is quite severely depressed. And what this angiogram showed is that she has a very long occlusion that starts about 5 centimeters into her SFA and continues all the way down into her popliteal artery below her knee. It's probably a 35 to 40 centimeter occlusion with a not terrible tibial runoff. She did not have any ulcers on her feet. And so I went ahead and I went through this. I used a laser balloon, stented it, and got a pretty reasonable runoff. Her ABIs at rest and exercise were normal. Her symptoms completely resolved, and she came into the emergency room about 3 days later because her right leg was swollen, painful, red, hurt. And the first thing they did in the emergency room was they ultrasounded it because they thought she had a DVT, and the ultrasound was negative. And so this is kind of classic reperfusion syndrome. This probably occurs, in my experience, about 10 to 20% of the time. Most commonly occurs after patients have had long chronic occlusions, not short ones that are 5, 10, 15 centimeters, usually involving most of the SFA and popliteal artery, and have been there for quite some time. I put these venous pictures in. I stole these from a venous talk that I give, but it kind of relates to what the problem is. This is an acute problem due to increased arterial inflow. The arterial bed downstream has been auto-regulated and is maximally vasodilated. And then you have a venous system that is chronically underfilled due to chronic ischemia. And the venous system itself has a tremendous amount of capacitance built into it. And so you end up with acute venous insufficiency. And that perpetrates kind of a feed-forward loop where more blood comes in, there's more reflux, the skin swells up, and it continues to get kind of worse and worse and worse. Compartment syndrome in this situation is very unlikely. This is not what you see with an arterial perforation into a compartment space. And the reason why is because there's a tremendous amount of skin capacitance the leg will dilate, the blood flow return takes the path of least resistance. So this is not a tremendous increase in the intracompartmental pressure, but just a general increase in the pressure in the leg. The differential diagnosis, obviously, or DVT, cellulitis can mimic this, but this is something that is very easily diagnosed with history alone. In fact, I tell many patients afterwards, I said there's a very good chance that your leg's going to swell up. If it does, please call our office. Don't go to the emergency room. We can take care of this problem pretty simply. It's not really a big deal. The signs and symptoms, again, erythema, warmth, tenderness, edema of the leg. They complain that their leg hurts, it aches, it's heavy, the skin burns, it throbs. And if it really gets bad, they can actually begin to weep fluid out of their skin and actually develop blisters and bullae. And you obviously don't want to let that get to that point, because then you're dealing with a whole other issue of secondary wound healing. But, I've instructed my nurse on standing orders, and patients call in, say my leg's swollen up. Really what this amounts to, and I tell patients very simply, this is like the dam broke. All of a sudden you've got a tremendous amount of blood flowing into the leg, and it's just not getting out fast enough, and they have acute venous insufficiency, and that's really what the problem is. And so the treatment is fairly simple if you think about the mechanism of it. When you look, again, this is from a venous lecture I give, but when you look at venous physiology, the normal functioning calf muscle, the calf pump, is very effective at emptying the venous volume with even one muscle contraction. And so typically what we do is we tell patients to, just keep your leg elevated and it'll go away. Well, if you think about it, that's actually BS, and it's actually bad advice, because unless you get your foot above your heart, there's not going to be any increase in venous return. So unless we have people sit like this with their feet above their head all day long, we're not going to increase the venous return back to the heart. What happens is when you tell people to keep their feet elevated, what do? They sit in their reclining chair with their feet up on a footstool. They sit there stationary. Their feet are still below the level of their heart. The blood is continuing to pool there, and even though their feet are technically elevated from the floor, it's really actually counterproductive in helping out the venous return. So actually walking, moving your feet, calf pump exercises, even if they can't walk, if they can just sit there and do this, and do calf pumps, it's going to augment the venous return. So the treatment for this is very simple. Walking, moving, being active, getting out of the chair, being active throughout the day. If it gets to be really bad, I'll give them a short course of diuretics like Lasix, 20 to 40 milligrams a day for 3 to 5 days, typically resolves the problem. Once you restore normal active valve function and you get rid of that acute venous insufficiency problem, the symptoms will permanently resolve. In compression stockings, compression therapy can also be very helpful, 20 to 30 millimeter compression stockings. Again, the goal is really you want to get to this before the skin starts to weep and they start to blister. And typically, in my experience, within about 1 to 2 weeks, this will completely resolve. It very rarely lasts more than that. So hyperperfusion is not uncommon following revascularization for long chronic occlusions. Again, this is due to an acute increase in arterial flow, an underfilled venous system that has a high venous capacitance. Symptoms are due to acute leg edema. You want to treat this before the skin breaks down, and the treatment for it, again, is very simple. Increase your activity, a short course of Lasix if necessary, and compression therapy, and the symptoms will typically resolve in a week or two. Thank you for your attention.
Eric, thanks very much. That was a great summary. My understanding is that Tucson is ready. So unless I hear back from the gentleman in the back of the room, we're going to go to our live case next. No worries. Thanks. Hello, Miguel. We're back
Oh,
with
hello,
you.
guys. We're back. All right. Well, we've been working away here, trying to get cross our T's and dot our I's. But thanks again for having us. You want to go there? I'm going to just walk these guys through the case. Again, thank you to Yaffer and everybody putting this meeting. It's amazing that they gave us the opportunity to share some of our experiences down here in Tucson, where we definitely love Donald Trump. I would just have to say that we had a change in operators. It was too much of a Hispanic influence, so we got an American guy next to me. This is John Pakanowski. He's not only my senior partner, but a really good friend. Rob's here also. We've got Dr. Fabella, and we have a great team of people with Ed Salazar, and I think Julia's a nurse, so thank you for everything. So let's go to the slides of this patient. This is case number 3, and our last case for today. This is a lady with a left lower extremity critical limb ischemia. She has a Rutherford 4, which she has actually, she has progressed from the last time I saw her in my clinic. She didn't have a wound, and now she has a small ischemic first toe wound. So her wound Wi-Fi classification would be wound 1, ischemia 3, with a very profound drop in her ABI and monophasic distal waveforms and a foot infection of 0. Previous endovascular intervention 1 year ago, and actually 6 months ago she underwent balloon angioplasty for severe in-stent restenosis. So her left lower extremity ABI is 0.3, her duplex shows in-stent restenosis greater than 90%, and popliteal occlusion right behind the knee with only one vessel outflow, that was the anterior tibial artery. So given that this lady has had the unfortunate route of those people that we treat for ISR, and we wanted to show some of those cases, this has been what it has looked before in the past. Show the next one. And as you can see, fairly aggressive in-stent restenosis, subtotal occlusion of the distal end next. And then a popliteal occlusion right there. It goes into the tethers out into this really skimpy popliteal artery in the next. Then you have the one single, that vessel that you see down there. That's our anterior tibial artery that unfortunately is the only outflow she has right now. So lots of pain, 4-foot gangrene. Well, not gangrene, small little ischemic wound. And so I would definitely, at this point, we have 20 minutes. We're not going to have a huge amount of discussion, but I would certainly like to hear what you guys would think in doing potentially in a case like this with so much disease and recurrent interventions into SFA.
Okay, Miguel. Peter Soukis, you've got an excellent
Hey, Peter,
panel
how you doing,
here.
man? Good to
Doing
hear you.
well. We have the luxury of having several excellent vascular surgeons on the panel, so I will play devil's advocate and ask them whether any of them would proceed with a femoral to distal tibial bypass here or try an endovascular approach first.
I would try endovascular first here.
Is there any available saphenous vein or no? Do we know?
We did a vein mapping. She had a failed bypass on the right lower extremity. The residual saphenous vein has unfortunately some collateral pathways, and the major diameter has been set at 3 millimeters. That's her largest GSV diameter.
What do you think, Sonia?
Okay.
Sorry, who's on? I
Swap
would
that
try
over, Ed.
endovascular therapy first. I think they're doing what Miguel is doing is exactly what the first line of treatment would be. Sort of go and get
Let's
your
put a
angiogram,
comfy
see what
catheter
you
here.
have, and then decide
See
where
that
your
long needle
problem is, and
taper
then
tip?
treat it accordingly. I would not consider this for a bypass, even though it's a failure.
Okay, so do you think I can have the remote control on a bag here for a second so I can walk you? Normally we have the time, and Ed and I coordinate to show you the images I want to, but this time around we didn't really get to that. So let me just quickly get a remote so I can quickly walk you through this. I want to show you, thank you, some of the things that we've done. Give me a second, John.
Yep.
So, yeah, our plan was, given that this lady has had aggressive in-stent restenosis, we wanted to give some degree of added value with anti-restenosis therapy. And so with that in mind, we actually went ahead and off cameras, we relined her superas and proximal, what seems to be an Everflex stent before, with actually Zilver PTX drug-eluting stents. After we did that, we had a large popliteal obstruction, which was probably one of the main reasons why she's had issues. And so let me just walk you into this. You saw the diagnostic images of the SFA. I'm not going to dangle too much on that because we did a couple of femoral popliteal cases earlier. We wanted to focus more on this popliteal lesion. So as you see, that artery tethers into that short occlusion. That potentially might be a collateral coming off the anterior. I wasn't able to get into that in the adenograde fashion, and that's the reason why we then decided to do a retrograde approach. So, Chris, if you have also a second at some point, I'd like to bring the attention to the anterior area of her proximal leg. When you come to the decision of doing a retrograde stick, and you don't want to, at least personally, and that's my personal feeling, is I don't like to go all the way down to the dorsalis pedis, but rather I go up higher where I have a better chance. In a case like this, where you know that lesion is actually located in the proximal AT, then I really don't kind of spend much time doing that. So under roadmap, eventually we got into that. As you can see, that's a small little collateral going into the anterior area of that artery. But once you, with a little patience, you can get back into that lumen and then redirect the wire. Honestly, I used to do this a lot with 014 wires before, and I've changed to just utilizing an 018 wire. I like the V18 control wire from Boston because it gives me a nice little, it's kind of hefty in the back, and you can push through some of those calcified popliteal occlusions. So moreover, I avoided using any sort of sheath because I thought it was probably going to be a relatively quick passage. And so we decided to just go sheathless. And we have, Rob, what was the catheter we use, a slip catheter? Trailblazer. Oh, a Trailblazer, 0.018 Trailblazer to secure that. And so after the needle came out, we did that. And of course, don't blame me. I know that there's an adapter. We don't have it at the hospital, but I shouldn't have my fingers there in the image. I'm sorry for that. But anyway, once we're there, the idea is now we want to focus on getting that treated. But because we were off cameras, just to show you quickly, this is what we did. Those are Zilver PTX. That's 6x100 Zilver PTX. The next one, 6x100. Interestingly enough, there's a gap there between those stents. I'm sure the gap wasn't the objective of the operator who did it at the time, but with the superas, we have that happen sometimes where you think you landed it precisely, and because it kind of accommodates later in time, then it probably pulled back and separated for them from that particular area. So this is, I think, where we're at. John, you did a shot of that post-dilation already?
Yep.
Where is it this one?
Yep.
And I think you had one before too.
That was
This
the
one.
upper segment.
Upper segment, okay. So, I mean, as you see here, it's looking nice and smooth already, this ISR, which was pretty much a squiggly channel, and now we have that. So we're gonna start going. I don't know, John, what's your feeling about starting to treat these with just a normal balloon angioplasty of the pop? Do you like using scoring balloons? Kind of what's your feeling, and would you mind stenting this popliteal on this lady who apparently has fairly aggressive disease and has probably re-stenosed anything we put on her that doesn't have any degree of drug elution? Can I have a torque? And then maybe you guys in the panel, what would you do? Would you consider going for DCB in this area? I think a little bit behind that, so I can go and recapture you. Pull that wire out, and I
this
can
is
try to-
Joffer. Great case, buddy. Doing a great job. 2 points. First of all, your thyroid is glowing, so get a thyroid collar. Secondly, great case. And, one point I want to bring up is, what are your thoughts about using a DCB? Tell me why you were thinking about putting a Zilver in here. And also, as we talked about earlier, actually in my case, I had similar case as yours as a complete instant occlusion. And, you know, someone had brought up Viabonds in that scenario as well. So I think, I mean, the point is that We have a lot of great therapies for ISR. There's no head-to-head comparison.
Really?
And so we're all
Nice
doing
job.
kind of what we feel
put
is
that right there
best,
for you.
but we don't really have any studies to show what is best. And so,
Wait,
what do you think?
Let me pull it out.
Well, tell me
Pull
your
that out.
thought process with
But
using
not
the
yet. Let me
silvers, putting
push the wire so I can.
stent sandwich.
When you get the wire out, we'll pull that thing out. So a couple of things. Well, first of all, I don't know if you saw that, but that's the luck of a virgin Costa Rican. When the wire just goes into the catheter,
Hey, wait a minute, I did that.
you
I
just
had the
put the
catheter
catheter
set.
there. I put the wire in it. Anyways, let me tell me when we're out of here. Let me push this.
Well, actually, you know what, Miguel? I'm going to let you do your work. Let's talk to the panel here. Let me let you, I know because you're working hard down there. Peter, what do you think? How do you do this? Stent sandwich, vibe on it, DCB, atherectomy?
So many choices, and
So many
it's really
choices.
nice to finally actually have some choices in the United States of America. You could have predicted that this would have been a very difficult antegrade
Okay, so we have
traversal of that popliteal occlusion. Whenever you see a popliteal occlusion that
So let's pull
ends
this
in
out.
well-developed collaterals, you can be pretty
me
sure you're
that,
likely to
3
be subintimal. And
Over
I think the
angioplasty.
operator should be commended for recognizing that and going pretty quickly to a retrograde pedal access. Once you get across
balloon. There's a
the
short
abyss
balloon.
there, the popliteal again is an area that ideally, if we don't have to, we probably don't want to put a stent in there.
What
This
is that
patient's
balloon?
already had in-stent restenosis, so I think my approach would be probably to debulk this with
Maybe use
laser
that.
first, use a scoring balloon, and if I get a decent result, probably finish up with a drug-coated balloon in the hopes of avoiding putting additional stent down there.
Eric, I know you would
my
say,
particular thoughts
laser to
about
stent,
that
so let's
was,
Any
I'm
other
sorry about
thoughts?
that. Yeah, for you were asking me, I was just mesmerized by luck here. But my particular thought on that, if you see the sub-analysis of a single arm that Zilber PTX did, there's about 172 patients out of the 787, I think, give or take, that registry had, where they actually were all instant restenosis. Granted, the mean lesion length for that was probably around the 13.8 centimeters, if I do believe that that's right. And their patency rates and freedom from TLR was pretty good. Thomas Seller, a good friend from Bad Klitzing, has actually published some of that data initially, and it looks good. So on the other hand, I mean, we're talking about 100 and something patients. On the other hand, earlier today, we did show our case where we did a reline. When it's longer than 25, 30 centimeters, we don't believe that using a Biobond graft is a bad idea. And so in that case, there is some data. It's not that much because we're looking at then data of 40 patients against 40 PTA only when you reline them with a with a core Biobond. So we just thought it was, that's probably the puncture site. Let's pull back a little bit there, not that much.
And
Let me
Miguel,
just
one
give
of
you
the
a little bit
techniques I
of
really like is you using a high AT stick. And
Uh-huh.
for
That's
all those
probably
that are
enough.
here today, remember we do
about
have the pedal access
Yeah.
cadaver course on Saturday, which is the
So
fluid
let's do a little
injected
shot. I'm going to take
pedal,
this wire out this way.
pedal access. And Miguel will also be there, and you can definitely get a hands-on approach in doing this high AT stick. And you can definitely practice that
Give
during
it
the
to me
pedal
back.
access course. But I
Yeah.
really like that technique. It gives you a lot more pushability than it does if you're accessing the dorsalis pedis. So great tip there.
Yeah, and then the whole trick here is ultimately once you pull and you want to rewire, you want to make sure you don't dilate into the track, which, I mean, I guess like anything in the life, when you do it enough times, eventually you do it wrong. And so I had one of my residents dilate outside of the puncture site, and that was a little bit of a mess, and we had to use one of those stent graft, master grafts. And for anybody that has used them, you don't know the amount of pain that creates for you and the paperwork. But let's do a little shot here. And so if we're still in that AT, pass down the reconstitution side. There might be some X-reb. I'm not concerned about that. Okay, that looks pretty decent. And so now we're going to see if we can just rewire that AT. Let me put some
Yeah,
saving
that
here.
does look scary, but you're absolutely right. You can just let that go. That's going to complete just thrombose off. So Eric, we were talking earlier about how you would treat that ISR.
Gotcha.
Yeah, I mean, this is the kind of data that we had with Excite. long lesions from Excite.
Yep.
20% of the lesions were over 30 centimeters in length, and they were pretty real world. But again, getting back to the point that we've talked
Very
about,
nice.
is that even
Well,
the
let's advance
TLR
past
rates at 6 and 12 months are by far from zero. I mean, I think that what Excite does is
That's
set a baseline to basically say that a plain balloon alone is a bad treatment. It doesn't work. I think the new baseline should be a laser plus a balloon, and then you can go from there. If you want to
Can I
add
have
a
a
drug
4 by
coated
100
therapy,
Vascutrac?
if you want to add a Viabond stent graft, I think those are good options. But I
This might
think
be
really
too big
the
of a
big
balloon.
take-home message from
unbelievable.
Excite
Yeah,
is that
let's
a
just leave it
plain
there.
balloon doesn't work, and that should not be what your default therapy should be.
Well, let's keep that one up a little bit.
The other thing I do
So
want to
we
point out too
opted
is
for a
that-
3, guys. What do you think? This lady's one a thin Hispanic, and that's a 3. I tend to push my tibials a little bit more than usual, but I think that might just be a little bit too large. But we'll have it at only 2 atmospheres, and we're doing endohemostasis. So the idea is to try to close up that hole. Let me pull out. Yeah, it doesn't look that bad. Yeah. Well, let's see.
I think
What do you guys
another
think?
point that Miguel was making about the extravasation afterwards. A lot of people have a fear about compartment syndrome with this, and they don't get that. These seal up just fine. Particularly when you don't put a sheath in, you just go with the wire or a support catheter, they'll be fine.
So just for the audience, what Miguel was talking about is, when you seal these up, when you balloon tamponade it, what you want is a 1-to-1 or just under a 1-to-1 balloon inflation, because what you're doing is you're not doing a balloon angioplasty. You're just causing cessation of blood flow so that the artery can heal on its own. And so sometimes, all you got to do, what I do is I look at the blood flow coming out of the access site, and I slowly go up on my balloon until I see the blood actually coming out of my access, and that's when I know I'm high enough. So remember, you're not doing a balloon angioplasty, you're doing a balloon tamponade.
Right, so let's just inflate this. Like I said, this is just a little balloon. This is a 3 by 100 018 profile. As I was saying in my last case, really an advocate of focal force balloons. I like them. I like to push a little on the limits, try to stay away from stenting that popliteal. So we'll see if maybe we can kick it up a notch with a 4 by 120 or 4 by 150 Vascutrac balloon. But we should have at least here a shot once John pulls that balloon out. And I've been informed that I have 10 minutes, so I think we have enough time to at least show you a preliminary result.
Yeah, I want to ask Dr. Wang a quick question. So we have a pretty nice looking artery there, the popliteal artery. Hopefully we'll get some pretty good results with balloon angioplasty. Let's say this was heavily calcified. Would you approach it differently?
So I would.
Yeah.
I mean, ultimately, when you have an extensive amount of calcium, you're going to have a lot of recoil if you don't do something to protrude that vessel. So typically, I personally would use a CSI device in that location. Obviously, you can use any device, well, not any, but other devices, but that's what I would use in that situation.
It looks good, Miguel.
Yeah, I mean, I think it's starting to look good. All our points have been gladly proven. There's not a whole lot of extravasation. If anything, it's let me see if there's even a puff. No, I don't even see a little puff. That's just collaterals. At this point, we're probably going to upsize that pop. We'll choose a bigger balloon, start at the tibial plateau with a 4 Vascutrac, crank it up to about 8-10 atmospheres, give it a couple of minutes and see what we got. But
So how
I'm
would you
liking what
feel
I'm
about
seeing, guys.
using
What
a-
about you guys?
How would you feel about using a DCB here?
I would feel good about using a DCB. I have a couple of things, unfortunately, politically wise, against them in the sense that my hospital didn't let us push it through. Probably there, John. Yeah, that's past the
surprising,
tibial.
even now with the,
The
incremental
first-
reimbursement as
Backing up.
well.
It's too far down.
Yeah, it depends on if you use the outpatient code, and it was honestly probably a little bit further back, just a centimeter or two.
I agree.
The first iteration that hit the market, had some constraints with the results in the U.S.-based female arm of the trial, and so some of our statisticians had issues with that. But we're about to have, I think, preliminary approval on the second one that hit the market. So we will have that, and I think it's certainly a possibility where we can show leaving no stent behind. I always say, I'm not about don't leave anything behind, but just leave the right thing behind, because ultimately I think some lesions do need a scaffold, and you shouldn't be afraid of dropping a stent, the right stent. This would be a position where I would have no problem whatsoever dropping a supera. We've got good data. We put it in JVS. We like utilizing popliteal superas when patients don't have surgical options, like it is her case. And so we would feel good about that.
Maybe we'll just open it up to the panel. I mean, assuming that you had a drug-coated balloon on the shelf, would that be pretty much most people's next move at this point? Andre, what do you think?
It's on.
Yeah. You know, I like the pedal approach in this situation, and I think it keeps you in that true lumen. So personally, I would have started with atherectomy here. I would have done Silverhawk. I would have probably externalized my wire from below, or put a catheter down, put a spider down, and then atherectomized. The only concern that you have with that, obviously, is not coming too close to the stent and grabbing the stent. And after you do that, the other advantage with that, I think, is that a lot of times these popliteals tend to taper a bit, and it can be a problem with viabonds if they're too tapered. I think the Silverhawk allows you to taper a bit the atherectomy as well, and then you can put a drug-coated balloon if you want as well.
Just to go back to our first question about whether this would be a bypass candidate or not. You know, patients who fail like this, who have in-stent complete occlusion a year after an intervention and now with rest pain, they're going to fail based on surgical literature and endovascular therapy, no matter what you do. They have very aggressive recurrent disease. So this is not the end of the story, obviously. This patient's probably going to have to develop something down the road. So leaving the stent behind in this patient, that's one problem, potential problem that I see, because you know you're going to be back 9 months to a year from now with a similar problem. Anything that you do where you don't leave something behind allows you to cross your next problem a little bit sooner. And with drug-coated balloon available, I know it's not available in your hospital, certainly I think this is a great place to use it. To use the drug-coated balloon not only in where the in-stent stenosis is, but I am a big atherectomy user, and I think the popliteal artery, when done correctly, is a good place to do atherectomy and then back it up with drug-coated balloon if you can allow that.
Yeah, you know, Jos Vandenberg did publish in the Journal of Invasive Cardiology earlier this year a small cohort of patients. It was 19 patients where he did laser atherectomy followed by drug-coated balloon. Average lesion length was 11 centimeters, and at 19 months follow-up on average, they had demonstrated a 91% primary patency rate. So certainly, I think we're hearing a recurring theme here of atherectomy followed by drug-coated balloon really seem to dovetail very nicely together, and combination therapy seems to be where we're moving.
Yeah, even in definitive AR, when we looked at directional atherectomy followed by drug-coated balloons, if you left the artery with less than 30% stenosis post-atherectomy and followed with a drug-coated balloon, you had greater than 90% primary patency at a year. And that's what we need. Right now, we're kind of past those days of 70% primary patency, 50%, 30% primary patency that we were seeing with balloon angioplasty. We're really getting the technology now where we can push the limits, and what we need is 90+% primary patency, and that's what we're going to see. And I think in the next couple of days we're going to be presenting the Majestic trial, which showed exactly that in drug-eluting stents in the SFA. So, I mean, this is a great time for PAD and PAD treatments.
That's a great point. My biggest fear, though, is that outside people are going to tell us that this combination therapy approach that we're all advocating is too expensive, and they're going to put some sort of constraints on the progression of the field, both scientifically by economic means.
Yeah, but you know what? The interesting thing is Zilver, a Cook, what they've done is they've done a great job at looking at economic analysis. So because they have so many years of experience with the drug-eluting stents outside of the U.S. As well, and they actually show some great data in terms of cost savings. And I think if you explain that to the hospital administration, and they're picking up on that now, the cost savings, short-term and long-term, is tremendous over bare metal stenting. So it's really interesting, good time for us.
All right, guys, I know that we're shy on time. I like the preliminary result we have here. I might just do some more prolonged inflation. I think DCB would have been a fantastic tool in this particular case, as you have all probably pointed out. There's good outflow down the AT. There's a little bit of spasm in the distal branches. Our wire was a little bit down further, and that probably was the reason. We'll give some nitro, but we feel comfortable with the result, and we'll probably work a little bit behind the scenes once we let you guys go. So if there aren't any further questions or comments, I appreciate all you guys being there. Jaffer, thanks for supporting us and making this happen. Chris Woolley, thank you for bringing your team down from Phoenix, making it a reality. And apart from that, I don't know, blessings to everybody.
Miguel, thanks very much. That was a terrific case, a very technically challenging case with really a terrific result. Congratulations to you and your team, and thanks for a great day of cases. All right, we're going to
Great job.
go ahead we're going to go ahead and switch back now to our lectures, and it's a great pleasure to introduce my co-moderator, Dr. Sonia Noor. Sonia's going to talk to us this afternoon about post-intervention AV fistula identification, surveillance, and management. Do they all need to be treated? Sonia, welcome.
Thank you, Peter. I want to thank Jaffer as he runs out of here for the invitation and the opportunity to put together a few topics that I thought would be interesting for us to discuss. What I had not bargained for is this is one of the topics I wanted to hear the experts talk about so I could learn a few things from it, because in the last 10 years of practice, there have been 2 patients of mine that I've had to deal with this, and I just wanted to see what everybody else's take was. The other thing I have to thank Jaffer for is being the second last speaker on the first day, so thank you. All right, so here we are. These are my disclosures. What I'm really focusing on today, and the reason I picked this topic is, we have some residents and fellows, and we try to teach and practice, and that doesn't always translate, but we're talking about iatrogenic fistulas that we cause when we do procedures. And so essentially, it's defined as a connection between the artery and the vein. And the 2 fistulas that I'm focusing on is one at access, which is usually groin access. And then when we do an intervention, sometimes you end up with a fistula. And what can the algorithm for that be? I did a lot of searching. And let me tell you, there's not a lot of literature that really gives you a good algorithm or a good sense of what you should do. So I'm sure there's a lot of discussion we could go into. The traumatic AV fistula information that I got is mostly military, gunshots, civilian injuries. And just to give you a little bit about the pathophysiology, when an arteriovenous communication occurs, whether it's iatrogenic or not, the natural history is what's going to happen to that fistula is dependent on the diameter of the connection between the artery and the vein. Whether the distal vessel is patent or not, what is the status of the collateral vessels, and what is the location. The flow through the fistula is maintained if the cross-sectional area of the AV fistula is less than 1.5 times of the diameter of the inflow. So in other words, what it means is your inflow and outflow has to be open for this fistula to not have continued growth and reversal of flow, which is what we do not want. And then over time, these AV fistulas can have continued proximal enlargement. There's degeneration of the arterial wall, and slowly, pulsatile flow will occur in the vein with arterialization. These changes are observed as early as 2 months after the AV fistula is formed, and they are established at 15 months. However, these changes are reversible if it is treated in 2 years. So again, the fistulas we're talking about, it's access related, so that's mostly in the groin. It's either between the common femoral artery, superficial femoral artery, and superficial femoral vein, or the SFA and profunda. And then the intervention related can be anywhere depending on where you're intervening on the artery, whether it's the SFA, popliteal, or the tibial. So to talk a little bit about both of these fistulas, usually the good news is they're small. It's a small shunt volume, which is compared to AV access shunt volumes. It's only 60 to 510, so it predisposes to closing. Occasionally, it's associated with the pseudoaneurysm. It's usually benign, and most of these close. You don't have to worry about it. So intervention-related AV fistulas, I tried to do as good as a search as I could to look at what is the incidence, and it's just briefly reported, anecdotal literature mostly. No one really knows. The interventions that are associated with this are angioplasty, excisional atherectomy, laser atherectomy, and thrombectomy. Not to say it doesn't occur with others, but this is basically what I found. There are certain predisposing factors, though, that can lead you to causing this more often than not. So if you have a really long CTO and you're trying to work around it, and if you're using a lot of atherectomy, it appears to be more common with atherectomy, oversizing the device, overzealous debulking, usually associated with pain because you've cut into the media, and if there's compromised outflow to begin with, those are the cases that you're looking to have this kind of problem. Peri-procedurally, if you see it, right away when you do the angiogram, you'll see there's rapid venous filling, there's a large AV fistula, and it's usually, if you look at the picture in the middle, it's that last cut, that one more cut that you were about to make before you thought you were done, and then the next picture is your outflow is completely gone, and you've got now this massive AV fistula with all the blood going back up into the veins. So your indication to treat, obviously intra-op or peri-procedurally, is if there's reduced flow or no outflow, you have to treat it. And this is fairly simple. All of us at some point or the other have had to face this problem. So you treat the outflow first, I think. You reduce your resistance to as low as possible. So blood's preferentially going to want to go downstream. And then a prolonged balloon angioplasty will tack up the wall, the tear, the dissection, whatever it is that caused this AV fistula to get covered. If that's still not adequate, a covered stent, if it's in the SFA or POP, whether it's balloon expandable or self-expanding, works well. If you're getting into the smaller vessels like the tibials, you may not have access to a covered stent, or it may be too small, and then a bare metal stent may be able to help. Coil embolization, immediately during the procedure, I would be worried about, not knowing where you would coil embolize. That's something that you would do probably more down the road. There is references to reversing your anticoagulation. That may help. I'd be careful about that as well. And then the surgical literature does allude to doing a surgical ligation of the vein above and below, and urgently doing a bypass if there is ischemia in the limb. But the bigger question is, the patient does well, the patient goes home, you see them back at about 3 months, or you see them back at 6 months, and you examine usually they're asymptomatic. Sometimes they'll have recurrence of symptoms, or the ABI will drop, or you're seeing something funny on the duplex. On physical exam, usually you don't find anything unless there's a pseudoaneurysm. It's usually non-tender in that area in the SFA or POP, but you may be able to palpate a bruit or a thrill. And then when you go on and you do your duplex, that's when you see something, a much more clear answer to what's going on. And sure enough, the ABIs may have dropped from your procedure from when you did it. If you do duplex imaging, you'll be able to see loss of triphasic waveforms in the artery proximal to it, and definitely reduced flow distal. And then probably your next step in the workup is to get a CT or MRA to confirm if you have that AV fistula or not. When you do the angiogram, often there's multiple collateral channels that are open that allow this. So it's not just one communication between the artery and the vein. And sometimes you need to cannulate both the arterial side and the venous side to really establish where it is. When you identify it, again, the first thing you do is make sure your outflow vessel is good, because what's keeping the fistula open is the high resistance downstream. So you treat that, and then you can decide if it's a large vessel or covered stent. Now, as I said, in my case series of 2, I was wrong both times about the length of the stent. Sure enough, I put the Viabon in, I did another angiogram, and the fistula was still there, the outflow still wasn't good enough. So I had to go back and fix the outflow and then put another stent, extend the Viabon stent, and then only was I successful. So be careful when you see something like this. You may think it's very simple, it's just a small area. It usually isn't. Bare metal stents do work according to the literature if you don't have a covered stent. If it's a chronic problem, like it would be in 3 or 6 months, you can embolize the AV fistula, or you embolize the venous side, but be careful of distal embolization of your coils. Sometimes you can do a combination of a covered stent along with embolization. And most, as I said, the anecdotal reports do indicate that with endovascular therapy does allow you 88 to 100% success if you do it this way. Surgical, If you're at the bifurcation, for example, if it's at a bifurcation of blood vessels and you're not able to do endovascular therapy, or if endovascular therapy has failed, you could do it. The quick and easiest thing to do is to do a bypass. There's so much degeneration of the artery and there's so much collateralization of the vein, it's really hard to get in there, do a clean dissection, and just treat that area. You could do a hybrid of part of it could be open and part of it could be endovascular therapy where you put the covered stent graft in and you excise part of it or you ligate the vein above or below. So that sort of summarizes the intervention-related AV fistulas that you can come across. So access-related, this is what is much more written about. We have fairly common incidence in most reports of 0.86%. Obviously, it has increased because we've been doing more interventions. We're using larger sheets. And again, these tend to spontaneously close as well, which is the good news at 38 to 81%. So in the groin, it's usually a common femoral or a superficial femoral artery with a superficial femoral vein, or an SFA profunda with a profunda vein if it's a low puncture. And predisposing, so again, prevention. You could actually prevent this if you could plan a little better. If you had a heavier patient, it was a woman. If you're going to lose a large sheath, probably better puncture technique, use ultrasound guidance. And if they're heavily calcified, end-stage renal disease or hypertensive, you're predisposed to having access-related problems. These patients usually do have symptoms if it's associated with a pseudoaneurysm because it's painful and there's a mass. If it's not associated with pseudoaneurysm, there's just a bruit on physical exam, most of them don't complain. Over time, if it becomes a large AV fistula, then they can go on to have distal leg swelling, fairly significant entire leg edema, and congestive heart failure. So the physical exam is essentially, it could be asymptomatic, or if it is symptomatic, you may have a mass. If there's a pseudoaneurysm, you use your Doppler like I showed you before in the other one, and then you usually follow up with a CT or an MRA or an angiogram. However, most of these patients are asymptomatic. It's usually an incidental finding. I follow at least 5 or 6 patients now who have groin-related AV fistulas that have not closed, have remained open. They just get 6-monthly duplexes. I see them once a year. Most of them are young patients who have had multiple procedures for cranial aneurysms or intracranial aneurysms that have require repeated angiography. But they're small. You can leave them untreated, but I think you should just keep an eye on them. The indications would be to treat would be if they're enlarging, if there's pain, leg swelling like I talked about, if there's distal ischemia with a drop in ABI, or now CLI emerges, congestive heart failure, or this patient is going to be on chronic anticoagulation, especially a young patient, and it's not going to close. So endovascular therapy is definitely the first line of defense, provided they have good anatomy. You can use a covered stent, you can do embolization, you can do a hybrid of covered stent and embolization. Compression therapy is something that they used before that really did not have a high success rate. And then there's always surgical therapy as well. For example, if it's in the groin and you don't want to put a covered stent, or there's going to be problems with access, or if it's in an area where you don't want to stent because you don't want to bend the stent, surgical treatment is certainly another option. You could coil embolize initially and then go in and treat as well. So thank you for your attention, and one more talk to go, right?
Thanks, Sonia. I just want to remind everyone before we bring up our last 2 speakers is there is a welcome reception immediately following the conclusion of our festivities in this session this afternoon. So our last talk, or really 2 talks, is on just some real-world complex cases and complications. This is going to be a case review, and I think Dr. Muhammad is going to start it off for us.
So good evening, everybody. So I'm going to present 2 complicated cases. Well, I'll talk more in my cases about the technical part more than review of literature or different methods. It's more about real complicated cases and how we dealt with it. So the first case is 58-year-old Caucasian male with past medical history of significant for 30 back a year, smoking, hypertension, hyperlipidemia, several months of intermittent claudication, Rutherford classification 4, not responding to exercise and medical treatment. He came for elective peripheral angiogram and possible intervention. This is one of the pictures which was taken with the peripheral angiogram. Definitely not something you like to see every day in the cath lab. So In our center, we had hard time in general referring for surgery, so we try always to do everything by endovascular. By angiogram, he had occluded right common iliac artery. So we decided to start with use the angled glide wire with an IMA catheter to try to cross over using 7 French sheet, which was placed in the right common femoral artery. I'll show the pictures after. Balloon angioplasty was performed using 60 by 150 ever cross balloon at 5 atmosphere in the common iliac artery. And second inflation was performed at 10 atmosphere, and the third inflation, 10 atmosphere each 20 seconds. And the repeat angiogram showed. So we have so far, we crossed to the other side. This is the balloon inflation and the iliac artery. Again, another picture taken. We have dual axis in the left and in the right. So the angiogram showing severe stenosis in the distal common aorta and the distal aorta and both iliac artery bilateral. So we decided to do with kissing balloon inflation by 7/0 by 30 Armada balloon. So this is a kissing balloon in both iliac and in the distal aorta. After the inflation of the balloon, we still have severe distal aortic stenosis, and we have bilateral ostial iliac stenosis. So we decided to place aortic stent graft to cover the area. So we did 2 per close devices deployed, and then the sheet in the left common femoral artery was exchanged to 8 French sheet. Through that, a GR4 catheter was placed, and the stiff endologix wire was placed in the abdominal aorta. Then the sheet in the left common femoral artery was switched to 17 French endologix introducer sheet. A 22 by 70 by 30 endologix stent graft was loaded onto the wire. Probably I'm going to skip a little bit of the technical part of the use of deploying the stent. The stent graft was taken off, released, and pulled down into the bifurcation. Here we're having, again, picture to see the distal the aorta. Again, so the stent was deployed. I'm sorry, I have problem with the pictures. Wasn't the order. The stent was deployed in the distal aorta, and then also in the bilateral iliac. Reliant balloon was taken also to expand the stent. 4 inflation were done at 2 atmosphere. So we have the stent, and the Reliant balloon is inflated to expand the stent. Again, another inflation. We're having good results so far. It's not moving. Again, balloon inflation. We still have to do the inflation for the right common iliac cuff. And this is where so we did the inflation in the right common iliac artery cuff. And this is what we see after the inflation. It's definitely not something you don't like to see at all. So, so we have clear rupture or major perforation in the iliac artery after the balloon inflation. And I think this is considered to be disaster in the endovascular area. I don't know what disaster could be more than this. So we have major perforation or rupture. So what we do at this point, the first thing you have to stay calm. So the right common iliac artery ruptured. There was a free flow at that point. The dopamine was started and fluid resuscitation was undertaken. So what we did at this point is we inserted the reliant balloon through the left common femoral artery to the level of the distal aorta. We inflated the reliant balloon to the level which was enough to occlude all the flow through the iliac artery. And then we inserted the armada balloon through the right common iliac, through the right common femoral, and we inflated to the level only to cause tamponade in that area. And after a long inflation of the armada balloon in the right common iliac artery, we left the reliant balloon in the distal aorta. We deflate the armada balloon, and we deployed Vioban cover stent. So, as you can see here with the balloon inflation and the iliac artery, and then deploying the Vioban stent to cover the whole iliac area. In general, we use a longer stent than what we use in a normal revascularization, just in case if the perforation or the tear is, reaching any of the smaller branches, so we don't want to miss any area. So we put long stent. Again, another, after the stent, balloon inflation. We can see that the perforation is sealed. So the Vioban stent was inserted over the bleed and it was deployed. Repeat angiogram show that the bleeding had stopped. Armada balloon was used to post-dilate the stent at 10 atmosphere for 20 seconds, and repeat angiogram showed adequate result. So this is basically one of the ways to stop the perforation in the iliac is to occlude. Usually when, I don't know if we have time to discuss it more, but usually when we do any CTO of iliac, we elect always to have dual access, at least even if we put 4 French in the other side to start with, just in case if anything happens, so we can rapidly, insert larger sheet and use it to deal with the complication. The way we used here, we elected here to go with, to obstruct the whole flow, and in the aorta to make the patient more hemodynamically stable until we deal with the perforation. So that's a case number 1.
Tim, I'm just going to interrupt you there. Unfortunately, our venous colleagues have been much more fastidious in terms of their staying on time, and since we're running behind schedule, I'm going to actually ask Dr. Starr to come up and give her.
Yeah, but you're talking about artery here,
talk.
not vein. Artery is more, serious issues. So it's okay.
Right. So that was a great case and a great save. Thank you very much. Well deserved.
By the way,
round of
every
applause.
year they cut my cases. I don't know if it's intentionally or not.
And now, so that you feel put out, I'm actually going to ask Dr. Starr to just present one case as well, so that way we can try to wrap up the session.
I just have some brief, minor cases, and I'll whiz through them. So I do realize I'm the last speaker, and I'm the only thing standing between you and happy hour, so we'll be quick. And I'm going to entice you by showing disgusting surgical pictures to get you to stay once I get my slides.
All right, they are working on it as we speak.
Okay. I don't know any jokes.
Again, after Dr. Starr is finished with her presentation, of course, we'd like to welcome everyone to join the exhibitors and our fellow attendees next door in the welcome reception.
Great. So let's move right along here. So obviously, femoral access is what we're talking about. We've seen a lot of great cases here today with great outcomes, but if you have that complication at the end where the patient ends up getting an RP bleed or a big groin hematoma and ends up staying for the next week or 2 weeks or going to an ECF afterwards, then it's kind of overshadowed what you've just done. The reporting standards for this is quite variable, so in the literature you can see quite a good range of complications reported. And I tell my fellows and residents it's all about imaging, so look at the femoral head, keep in mind the inguinal crease, in Ohio at least, is at the popliteal fossa sometimes. But in ultrasound guidance is really important to get an anterior stick, avoid sticking the back wall. And remember at the end of the case, before you're putting any type of closure device in or deciding that, is to get a completion angiogram that is kept, not just a run, but a real run where you can keep the images and go back and look at them if you need to. These are the obvious laundry list of complications. I don't know why distal embolization made it twice on the list, but a whole host of things can happen. I'm going to mostly talk about causes of access site complication and devices in just a minute. Pseudoaneurysms can be caused by all of these reasons here. And I know we've talked about a lot of these today. Bleeding, obviously, because usually bleeding is because of too high of a stick or even too low of a stick as well. Patients who get up to the bathroom, an hour after they're allowed to get up and strain. And obviously, as Dr. Moore mentioned, AV fistula is when you've stuck too low, typically. This is what a pseudoaneurysm looks like on duplex examination. You can see the common femoral artery at the bottom and the vein. And this is a bilobed pseudoaneurysm, which we would typically inject with thrombin. However, bleeding can cause this sort of problem, and this is something that shouldn't be ignored for, well, it's a hematoma, it'll get better. And if you can, I don't know if you can kind of appreciate in the middle of the screen that there's some blistering of the skin. So this is actually going to be skin necrosis, and if not taken care of in a timely fashion, this patient can end up with a huge gaping wound and months of treatment for this. This is what a side stick looks like in the common femoral artery. There's an incision there. Actually, this operation was not done for an angioceal complication, but it just so happened that I noticed that the angioceal was stuck on the side of the vessel. You can see the anchor hanging outside the artery. It's actually appropriately placed, but it's obviously not where the stick should be placed. The first case quickly is somebody who had a heart cath in the right groin, had right heart failure. Dr. Noor talked about this. There was a bruit over the groin and a duplex was ordered. Because this patient had some heart failure, we did opt to fix this. You can see the size of the AV fistula between the artery and the vein is quite sizable. This is the superficial femoral artery. Basically put a little stitch on each side and we're done with the case. It's sort of anticlimactic when you're done with it. Here's another one showing a posterior stick between the artery and the vein as well, which typically runs posterior to it at a certain level. And this was a huge one, and Dr. Noor talked about arterialization of the vein, and you can see, although where the blue arrow is, you think that's a branch, and that's actually the AV fistula running to the vein, and this was a young woman who had heart failure as well, and the reason why we fixed this. Next case is someone with buttock claudication who was found to have an external iliac artery occlusion on the right. The left femoral was accessed. 3 weeks later, they presented our facility with a pulsatile red mass in the left groin, so the access groin. This turned out to be infectious, so we did operate on this. You can see the forceps are on the residual perclose stitch. It's very rare to actually see a perclose infection. I've seen many more angioceal infections. But that hole in the artery is not one that I created. It was actually where the artery had been eroded and where the pseudoaneurysm originated from. So this artery was freshened up and a vein patch was placed. This is another case, and this is very common. I bring it to everybody's attention because I think we sometimes ignore that, and sometimes this comes up in medical legal issues of people who soon after their procedure will complain of a funny feeling in their leg or it just doesn't quite feel right. Usually they'll tell the nurses. Sometimes they call the physicians. Sometimes they don't. The patient gets discharged, and usually it's about a week later they come back in with short-distance claudication that they never had before. This one showed a retained foreign body, and obviously on the angiogram you can see it in the middle of the screen as a filling defect, which was an angioceal as well. Here's the picture of the operation from that. You can see the angioceal is half in and half out of the vessel. Again, this is the common femoral, and this is after we've removed it. What it looks like as we're trying to access it, you can see the thrombus on top of the closure device, and I just thought this was the coolest picture because it was probably the longest clot I ever retrieved. Yeah, I thought it was, that's why I laid it out and had to take a picture of it quickly. This is what it looks like if you leave an angioceal inside and miss the fact that it was inside. It becomes covered kind of with an intimal surface and kind of an eccentric lesion. Again, this got treated because the patient had symptoms that recurred. This was a kind of a very interesting one, which was a star close, and I've only seen it one time. Patient had worsening calf claudication, and I was asked to see the patient. And on the angiogram, there was a common femoral stenosis. I don't have those images, but you could see it was right where the retained star close was. In surgery, you would have thought that was the star close site. In fact, it was not. I opened the artery and found sort of this anterior arterial wall tacked down to the back wall. After I freed that up, you could see that indeed the star close was embedded in the back wall of the artery. There was plaque posteriorly. So I basically trimmed that out and put a small vein patch angioplasty of this area. This is another one that I don't see very often, but it was a perclose that was actually, there's probably some overlying lip of plaque and was caught up in the perclose, and you can see the thrombus that was proximal to that. So the perclose is actually on the inside of the artery in the back wall. I think this is the last case. This is a patient with heart cath. Angioceal device was utilized. They attempted to, it was retained, and they attempted to do a Silverhawk atherectomy. Patient had sudden onset of foot ischemia, and on completion angiogram had abrupt cutoff of the popliteal artery. Was taken to the operating room by my partner, and this is the big incision that you get if you get a angioceal in your popliteal. This is the arteriotomy that we make to pull out this clot, which is basically what it looks like. And that was some of the device as well. So what to do to avoid this, to keep what you just did looking good to the patient and keep the patient healthy is consider using ultrasound guidance. I will admit I don't use it as often as I should. I'm using it more and more that my fellows are now educated, but it tells you that whether or not the artery is patent, because indeed sometimes pulses aren't palpable because they're calcified, sometimes because the vessel's occluded. It allows you to stick the anterior wall, check for plaque on the anterior wall, make sure there's an adequate size for the closure device, and make sure you're sticking the common femoral artery. So I would encourage you to use the closure device of your choice with which you're most familiar with, as has been mentioned before today. Follow the instructions for use. There's a reason why they're there. And again, be cognizant of when you get called afterwards and the patient's had a change in their symptomatology. Ooh, was that good? Thanks. Quick.
Yeah. Very well
That's
done.
the fastest I've ever talked.
Great cases, and more importantly, very punctual. Thank you very much to all of our speakers, but of course, more importantly, to all of you for sticking it out here to the bitter end. Thank you for your attendance and your attention, and let's all go next door and have a nice glass of wine. Thanks very much.